Hello, my name is Dr. Sindhu Johnson, and I'm a professor of medicine at the University of Toronto. I'd like to thank RheumNow for giving me the opportunity to share with you the American College of Rheumatology, American College of Chest Physicians guidelines for the screening, monitoring, and treatment of systemic sclerosis-associated interstitial lung disease. I was supported by the American College of Rheumatology to develop this work. In the past, I've been supported by EULAR to develop classification criteria for systemic sclerosis as well as systemic lupus. And I've previously served on the steering committee of the American College of Rheumatology guidelines for vaccinations, for which I now receive royalties from UpToDate. With regards to potential conflicts of interest within this presentation, I have previously served as a site investigator on several clinical trials for data that informed this guideline, notably for tocilizumab and nintedanib. The steps I've taken to review and mitigate these potential biases are that I have given up all pharmaceutical relationships 1 year prior to the development of the ILD guidelines, and I will continue to do so for at least 1 year after its publication. Clinical practice guidelines. These are considered among the most important documents that the American College of Rheumatology and American College of Chest Physicians produce for its membership. It has a number of objectives, but its primary objective is to guide healthcare professionals. Its secondary objectives are to reduce geographic practice variation. A patient's treatment options should not depend on where they live. Finally, clinical practice guidelines can be used as advocacy documents and awareness documents. If a payer does not cover a specific test or a specific treatment, groups can use clinical practice guidelines to help advocate for their coverage. The American College of Rheumatology, American College of Chest Physicians guidelines cover several groups of recommendations. The first group of recommendations relates to who should be screened. We know that systemic sclerosis confers an increased risk of developing interstitial lung disease compared to the general population. However, the risk of developing ILD and the risk of progression can vary across subsets or groups of patients. In the document, we outline a number of risk factors for developing interstitial lung disease and progression of interstitial lung disease. These include autoantibodies, such as SCL-70 and anti-nuclear antibodies with nucleolar pattern, the diffuse subtype, male sex, African American race. Patients with early disease, that is the first 5 to 7 years after onset, are at increased risk of developing ILD, and those with elevated acute phase reactants, such as ESR and CRP, also confer an increased risk of developing ILD and disease progression. So when it comes to screening for ILD in people with systemic sclerosis, the American College of Rheumatology conditionally recommends pulmonary function testing and high-resolution CT chest. Now, clinical pearl number 1. A pulmonary function test should include spirometry, lung volumes, and diffusion capacity. Often, pulmonologists will use office spirometry to monitor disease. However, spirometry alone is insufficient. We should be ordering full pulmonary function tests. Clinical pearl number 2. A scleroderma patient who has shortness of breath may present to the emergency department, and there they will receive a CT angiogram, often because the emergency doctor wants to rule out pulmonary emboli. However, it's important to note that a CT angiogram is performed in incomplete inspiration to maximize pulmonary artery enhancement, and this may produce atelectasis that can obscure or mimic ILD. Therefore, a CTA is inadequate to screen for ILD. A patient needs a high-resolution CT chest. Once a patient has been diagnosed with interstitial lung disease, the next grouping of recommendations relates to monitoring of ILD. The American College of Rheumatology and American College of Chest Physicians guidelines conditionally recommend pulmonary function testing, again with spirometry, lung volumes, and diffusion capacity. It is suggested that in systemic sclerosis, PFTs occur every 3 to 6 months in the first year and then less frequently once stable. The second monitoring test is ambulatory desaturation testing every 3 to 12 months. This may be new to many rheumatologists and certainly does not fall within our scope of practice. However, This test falls within the scope of practice of a pulmonologist, and here is one of the many reasons we should be sharing care with pulmonologists. A clinical pearl is that a 6-minute walk test with continuous oximetry is insufficient. Ambulatory desaturation testing includes up-titration of oxygen. The third monitoring test is high-resolution CT chest as needed. With regards to other screening tests, there are several that have conditional recommendations against. These are chest x-ray, 6-minute walk test distance, ambulatory desaturation testing, and bronchoscopy as screening tests for ILD. There is a strong recommendation against surgical lung biopsy as a screening test for ILD. However, there may be other reasons why one may choose to perform these tests. For example, if a patient has difficulty performing PFTs, a bronchoscopy may be required to rule out infection, sarcoidosis, lymphoma, or alveolar hemorrhage. A surgical lung biopsy may be used to rule out malignancy. Similarly, there are conditional recommendations against the use of chest x-ray, 6-minute walk test distance, and bronchoscopy for monitoring ILD. However, these tests may be used if a patient has difficulty performing PFTs or to rule out infection or alveolar hemorrhage. The next grouping of recommendations relates to the first-line treatment of ILD in people with systemic sclerosis. The treatment options are presented as preferred, that is, those that are expected to be most commonly prescribed, and additional therapies, those that may be used in certain situations. There are many situations that might lead a provider to choose a different treatment option for ILD, for example, comorbidities or extrapulmonary disease activity. And so I'd like to draw your attention to the first green box labeled systemic sclerosis. You will see there are a menu of treatment options as first-line ILD therapy. The first indicated therapy is mycophenolate. And as you can see, this is the first-line therapy across several systemic autoimmune rheumatic diseases. However, one may consider tocilizumab, rituximab, cyclophosphamide, nintedanib, or azathioprine as a first-line ILD treatment in systemic sclerosis. There is a strong recommendation against the use of glucocorticoids in people with systemic sclerosis-associated interstitial lung disease, and this is due to the increased risk of inducing a scleroderma renal crisis. Now, while this may be common knowledge to most rheumatologists, many of our pulmonology colleagues are not aware of this, so here is an opportunity for you to educate our colleagues in your consultation notes. The next grouping of recommendations relates to progression of ILD after first-line therapy. For the purpose of the guideline, the inbuilt criteria for progression were used. However, you do not have to use these criteria. Again, I'll draw your attention to the first box labeled systemic sclerosis. Again, there is a menu of options that one can choose from. In this case, if mycophenolate was not the first-line ILD therapy, a second-line treatment would be mycophenolate. However, one could also consider rituximab, nintedanib, tocilizumab, cyclophosphamide, as well as referral for autologous hematopoietic stem cell transplant at an experienced center. There is a strong recommendation against long-term glucocorticoids in people with systemic sclerosis-associated ILD, again due to the increased risk of inducing a scleroderma renal crisis. One may also consider at this point referral to a lung transplant center for evaluation due to their progressive disease. The final grouping of recommendations relates to rapidly progressive ILD. That is a subpopulation of ILD characterized by rapid regression from no oxygen or a patient's baseline oxygen requirement to a high oxygen requirement or intubation. Usually this occurs over days to weeks without a documented alternative cause, such as infection or heart failure. Rapidly progressive ILD is considered a new disease of our era, and typically associated with inflammatory myositis, those who have MDA5 antibodies. However, rarely it can be seen in people with systemic sclerosis. In this situation, the guidelines conditionally recommend combination therapy with intravenous glucocorticoids as well as two additional therapies, rituximab and cyclophosphamide or mycophenolate. However, I will share with you that many high-volume centers in the US tend to prefer IVIG and calcineurin inhibitors such as tacrolimus, and this is largely due to their concerns about increased risk of infection in an intubated patient on rituximab or cyclophosphamide. The guideline document contains additional tables. One relates to medication dosing and monitoring. This may be helpful for medications that you are less familiar with, such as tacrolimus. In this table, we outline the starting dose, frequency, and monitoring recommendations. There are additional tables that highlight other interventions that one might consider in the treatment of scleroderma-associated ILD, but were just beyond the scope of the guideline. This includes exercise, palliative care, physiotherapy, pulmonary rehabilitation, and supplemental oxygen. There are also other pharmacologic therapies, such as gastroesophageal reflux management, PJB prophylaxis, pro-motility agents, and vaccinations. I was involved with the ACR guidelines for vaccinations in people with rheumatic diseases, and I'd like to draw to your attention rituximab. It's conditionally recommended that we should continue rituximab in patients who need it. However, with regards to the influenza vaccine, we should continue to give it on schedule, but delay subsequent rituximab dosing for at least 2 weeks after the influenza vaccine, if disease activity allows. And this is to help the immunogenicity of the vaccine. With regards to the COVID vaccine, it is recommended with regards to cyclophosphamide that we time cyclophosphamide administration that it occurs 1 week after each vaccine dose when feasible. And finally, with regards to the other conventional and targeted immunosuppressive therapies, such as JAK inhibitors and MMF, it is recommended to withhold these medications for 1 to 2 weeks as disease activity allows after each COVID-19 vaccine dose. So, in summary, the ACR CHEST guidelines provide a risk-based approach to the screening and monitoring of ILD in people with systemic sclerosis-associated ILD. It provides a range or a menu of treatment options for these patients. And these treatment options are based on the best published evidence, expert experience, and patients' values and preferences. If you would like to review the document for yourself, it is freely available to all ACR members. You just go to their website, rheumatology.org. There you'll click Clinical Tools and Guidelines, and you will find the ILD guidelines. The guidelines are also freely available on the ACR Clinical Practice Guideline and Criteria app. This can be downloaded from the Apple Store or from Google Play. I'd like to thank everyone who was involved in the development of these guidelines. And finally, I'd like to thank you for your attention.